Good morning, everyone, and welcome to today's webcast, Primary Care Conversations. My name is Corinne Pettit, and I'll be your moderator for tonight's presentation. Before we get started, I'd like to go over a few items so that you know how to participate in today's event. We've taken a screenshot of the attendee interface. You should see something that looks like this on your own computer's desktop in the upper right corner. You've joined the presentation listening using your computer's speaker system by default. This means that if you can hear music through your computer, you should be able to hear the presentation. If you'd prefer to join over the telephone, just select Use Telephone in the audio pane and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's presenter by typing into the questions pane of the control panel. You may send in your questions at any time during the presentation, and we will collect these and address as many as possible at the end. Before I introduce today's speaker, I'd like to take a moment to tell those of you who may be new to the Foundation about who we are, our mission, and what we do. In 2014, the National Psoriasis Foundation developed a new strategic plan which drives everything we do as an organization. To achieve our mission, the following goals were identified: accelerate discovery to cure psoriatic disease, improve health outcomes, and achieve goals to help reach our mission, whether it's being involved with an event or becoming a volunteer. By attending today's program, you've already taken a step towards expanding your knowledge about psoriasis and psoriatic arthritis to help manage your disease and find others who understand what it means to live with psoriatic disease. You can help accelerate efforts towards the cure and greater understanding of psoriatic disease by participating in the NPF Corona National Psoriasis Patient Registry, which is the largest independent observational registry of psoriasis patients in the U.S. The registry, which involves a network of dermatology clinics, collects and studies patient health information, allowing researchers to compare the safety and efficacy of psoriasis treatments, better understand the conditions that are related to psoriasis, and explore the history of the disease. You can also share your experience with researchers about what it means to live with psoriasis and psoriatic arthritis by participating in Citizen Scientists. Answer questions and view your data along with over 5,000 participants. Data is used to help researchers gain a better understanding of the disease. To learn more and participate, please visit the website listed on the screen after tonight's presentation. We continue to improve health outcomes through our Patient Navigation Center, the world's first personalized support center for people impacted by psoriatic disease. The Foundation's Patient Navigation Center is available to help you find physicians, treatment information, navigating insurance issues, access support through our one-to-one program, and more. Contact us at 1-800-723-9166 or visit psoriasis.org/navigation center. To achieve the Foundation's goals as mentioned, please support our mission to fund research, educational programs, and support through donations or by participating in Team MPF events such as walks, runs, cycles, or bingos. To find an event of interest near you, please visit www.teammpf.org. On behalf of National Psoriasis Foundation, I'd like to recognize our sponsors, Celgene and Lilly. Without their support, this educational program would not be possible. Thank you for your support. Now I'd like to introduce today's speaker, Dr. Martina Porter. Dr. Porter completed her dermatology residency training at Roger Williams Medical Center and Boston University. Through the American Board of Dermatology's Special Investigative Training Track, she spent her third year of residency as the Clinical and Research Fellow at Massachusetts General Hospital with a focus on clinical trials, specifically in psoriasis, hidradenitis suppurativa, and eczema. She also completed an additional research fellowship at Beth Israel Deaconess Medical Center, where she started a new clinical trials unit, the Clinical Laboratory for Epidemiology and Applied Research, with her mentor, Dr. Alexa Kimball. The National Psoriasis Foundation has also supported her research career through fellowship grants. She's developed an expertise in the design and conduct of clinical trials, as well as the development and validation of disease-specific scoring systems. She has written multiple articles about psoriasis, focusing on psoriasis and pregnancy, as well as the costs of psoriasis treatments. Her specific research interests include women's health, psoriasis, hidradenitis suppurativa, and alopecia. Welcome, Dr. Porter.
Thank you so much, and hello to everyone, and welcome to our NPF patient webinar. I'm excited to participate in this event here from Boston. I just wanted to go over a few things related to the format of this presentation. So I'm going to start out with a 30-minute presentation about psoriasis in general, and then we'll follow this with a 30-minute question and answer session. And our moderator, Corinne, will be helping to select questions that you guys submit. but we already have multiple questions submitted. Some I'll try to address during the presentation itself, but please feel free to continue to submit as many questions as you would like throughout the presentation, and we'll try to answer as many of them as possible at the end. And just as a note, anything that you see on the screen is actually not live, so you won't be able to click on any of the links, but there will be a resource page available at the end of the presentation for any of the links that I mentioned, and you can write down the web addresses from there. Well, skipped a slide, but so I just wanted to go over what is psoriasis. So psoriasis is an immune-mediated disease that causes these red scaly plaques to appear on patients' skin. So what we tend to see first is that patients with psoriasis have skin cells that just grow much faster than the average person. So for a normal person, you may see skin cells maturing in 21 to 28 days, but for psoriasis patients, the same maturation process only takes about 4 to 7 days, and that's why we think that people get these kind of overgrowth of the red scaly plaques on the skin. And what we know about the type of people that get psoriasis right now is that it's equally men and women. And they think overall the worldwide prevalence is somewhere between 1 and 4%, and some studies will say the average is about 2%, but it kind of varies depending on the country that you live in. We also know that psoriasis can affect any race. We see it a little bit more in Caucasian or white patients as compared to African American or Black patients. But everybody can get psoriasis, and psoriasis also tends to occur at any age. There's two prime peaks in terms of age of onset. One is in the late teenage years through the 20s, and the other is in middle age in the 50 to 60-year-old range. And we think about 75% of patients who get psoriasis will get it before the age of 40. And the other thing we know is that psoriasis tends to last a lifetime. So we have some other skin diseases that tend to go away as you get older or go through menopause or your immune system becomes worse. But we have multiple patients here who still in their 80s have psoriasis that's just as active as it was when they were younger. And what does psoriasis look like? It can have many different appearances. The most common type is what we call chronic plaque psoriasis, which was like the picture of the elbow that we showed before, but also you can get those same plaques here in your scalp. You can also get them on your elbows or your knees, but it can occur anywhere on your body. And one of the other things we look for often when we see patients who have skin lesions that we think are psoriasis is to look at their nails, because they'll often have different changes of their nails. And some of these will be these little tiny pits that you'll see in the nails. Other changes are this separation of the nail plate here from your finger. And then a lot of times people will also have these kind of crumbly nails that some patients will have been told in the past were fungal infections. And then there's also a little bit of this yellowish brown discoloration that we'll call oil spots. But there's some other types of psoriasis as well that are a little bit less common. These include inverse psoriasis, where patients have lesions in their skin folds, like their gluteal cleft here, their armpit over here, under their breast is also common. There's a variant of psoriasis called pustular psoriasis, where patients will get these little tiny pustules or pus bumps on their psoriasis plaques. And then there's a more severe form of psoriasis called erythrodermic or erythroderma psoriasis, where patients' whole body will become one big red scaly plaque. And then what we often see in kids or people who are about to flare with their psoriasis is a type of psoriasis called guttate psoriasis, where the plaques are these little tiny red spots, and some of these will just stay this size, and some people with this type of psoriasis will actually go on to have plaque psoriasis as well. And then in terms of the cause of psoriasis, in the last probably 15 years, we've learned a lot more about the different immunological and genetic factors that play a role in the development of psoriasis. And many of our new therapies, such as the biologic treatments, are really targeted at the different immune mediators that are in the pathway for causing psoriasis, which is why they're so effective. But we still don't know the exact mechanism or the exact genes that cause psoriasis. although we're getting much more knowledgeable with time. The other thing we know about the cause of psoriasis is that a lot of patients will report that there was some sort of trigger that either caused their psoriasis to first occur or causes their psoriasis to flare up. And one of the most important ones of these triggers is actual stress. And some people will report it as medical stress, where they just had an illness or an infection and they were on antibiotics and then their psoriasis flared up after that. But even things like emotional stress, patients going through divorces, losing their loved ones, just being very stressed out at work or in their relationships, they can also have flares of their psoriasis. And then there's another type of phenomenon called Kebnerization, where any sort of injury to the skin essentially causes psoriasis to occur in the exact same pattern where the skin injury was. So if you look over here to the right, both of these photos show a patient who's either scratched or slightly cut their skin. And in that scratch or cut, they actually develop a line of psoriasis that exactly follows where the trauma to the skin was. We also know that certain medications can cause psoriasis. The most common ones are lithium, which is a type of medication used to treat bipolar disorder or psychiatric conditions, antimalarials, which some people take for other autoimmune diseases, various types of blood pressure medications, including beta blockers, and then some other nonsteroidal anti-inflammatory medications as well. And then also infections, particularly streptococcus infections, the ones that can cause strep throat. And there have actually been some studies looking at children who developed strep throat frequently, who had psoriasis, and then had their tonsils removed and no longer had strep throat infections, and then had resolution of their psoriasis as well. Other things that people have mentioned as causing their psoriasis to flare or being known as a trigger of psoriasis, including allergies, different dietary changes like very high glycemic index foods or milk-containing products, particularly skim milk products, and weather such as the cold weather and rarely very hot weather can trigger psoriasis, but those don't have as much evidence behind them and they're not as universal as some of the things that I had already mentioned. And just so everyone knows, I just wanted to point out that psoriasis is not contagious, so you cannot spread psoriasis by touching other people or coming in contact with them. And you can tell other people that your skin disease will not spread to them just by touching you. And then how is psoriasis diagnosed? So the main way for us to diagnose psoriasis is through a clinical diagnosis. And what that means is that we don't use any special blood tests or tests. We just look at your skin and we say, this looks like psoriasis. And that is the way that the majority of patients are diagnosed because there aren't that many things that look exactly like psoriasis. Sometimes we'll request that patients have a skin biopsy to confirm the diagnosis or to confirm the diagnosis when psoriasis is not quite as clear cut. And there's two different ways that we take skin biopsies. One is that we'll shave off of a piece of your psoriasis and send it to the pathologist. And this will be a very shallow biopsy that heals with no stitches. The other way is to take a punch biopsy where we take a small sample, but we go much deeper into the skin and you'll often need stitches following this. But the reason that we do this is to compare the findings under the microscope to what we expect the pattern to be of psoriasis under the microscope. And the other really important thing about making a diagnosis of psoriasis is really discussing patients' history, including their family history, because we know about 1/3 of patients with psoriasis have a positive family history, meaning someone else in their family has the disease. And in case people were wondering, there was a large survey based in Germany many years ago where they looked at the risk of children developing psoriasis when both of their parents had it, and they found that that was about 40% if both parents had it versus only 14% if one parent had it, or only 6% if neither parent had it and just a sibling had psoriasis. And then after the diagnosis of psoriasis is made, the next step that we usually follow is figuring out how severe the disease is. And when you look at different clinical trials that evaluate whether or not medications are helpful for psoriasis, they use a lot of different scoring scales. Some of them, like the POSI and the PGA and this palmoplantar psoriasis surface area and the nail psoriasis severity index, have a more complicated method where they look at the amount of body surface affected, the thickness of your plaque, the redness of your plaque, how scaly it is, and they come up with a severity score. But we tend to not use this in clinical practice. What we mostly use in clinical practice is measurement of body surface area. And this is a much more convenient tool to use. And essentially, you at home can even do the same thing, where you look at the size of your hand and you look at just your palm, and that's equivalent to about 1% of your body surface area. So for people with mild psoriasis, we say that they have less than 3% of their body surface area or less than 3 of their own palm prints. People with moderate, we classify between 3 and 10% of their body surface area or about 3 to 10 palm prints. And severe psoriasis, we classify when you have more than 10 palm prints of psoriasis. And just so you know, one of the other things that they do measure when they look at psoriasis severity is the effect on patients' quality of life and also the number of symptoms they have. And something like the Dermatology Life Quality Index here, it measures like how severe patients' life is impacted by having their skin disease. And then once your psoriasis disease severity is obtained, we then talk to you about treatment options. Over the past 15 years, we've really advanced our treatment tremendously for psoriasis. They used to admit patients to hospitals to try to treat them, but there is currently no hospital in the country where a dermatologist admits patients because we don't need to take care of psoriasis patients in the hospital anymore. We have a lot of good medications, both topical medications and oral or systemic injectable medications that we use now for psoriasis therapy. And even though these medications tend to control most people's disease, we still don't have a cure. And it tends to be that once patients stop treatment, they may go through a period where their disease stays away, but it often tends to come back if they are not treating at all. And this is kind of our algorithm for how we progress along with therapy. So topical medications we tend to use for people who are more mild. And phototherapy is another option for people who are kind of in the mild to moderate range. And then if these two don't seem to be good enough for patients who have more severe disease, we tend to recommend systemic medications like biologics or oral systemic treatments to use. And if you guys have any questions, the NPS Patient Navigation Center, and the link will be at the end, really can help people understand the differences in treatments and the risks and benefits of the different treatments. And these should also be discussed with your healthcare provider. So psoriasis therapy should really be determined by your healthcare provider, but the one thing I will stress is that patients should make sure that their preferences and their overall health is also being considered. And this means that if you don't want to use a topical medication or you're afraid of the side effects of one particular oral or injectable medication, your provider should really work with you to figure out what would be the best option for you. And like I mentioned previously, we tend to use topicals or phototherapy for people who are mild, including on some of the more sensitive areas, like the hands, feet, face, or genitals. But for patients who are moderate to severe, which is the 3 to 10% and the 10% or more body surface area, we generally require stronger or more aggressive treatments. And these were the biologics and the oral treatments, and they can be used in combination with phototherapy or topicals as well. And then I just would also like you guys to know that treating psoriasis is not an easy process, and that we don't really have good guidelines telling us what is an acceptable response. But the National Psoriasis Foundation has really put forth some new guidelines where they call treat to target goals, where they think that patients' goals should be to get down to 1% or less of body surface area within 3 months of starting a new treatment. And that an acceptable response after 3 months, if you can't get to that 1% body surface area goal, is for your psoriasis to cover 3% of your body surface area, or that you've had a 75% improvement in your overall body surface area. And why is it important to treat psoriasis? What they really know about psoriasis is that some patients choose not to treat, but we really want patients to try to treat their disease because we know it can really impact their quality of life. And many years ago, they did a study in Canada with medical students where they actually stuck fake psoriasis lesions onto the student's skin and told them that they were going to walk around for a week and see how it felt to have a skin disease. And by the end of the first day, almost all the students had removed them because they felt so embarrassed by their skin lesions. And it helps people realize that even though um, skin disease may not be something that immediately causes a lot of negative health outcomes, it can really affect patients' qualities of life, and it can be from the symptoms itself, like the itching or the burning or the stinging, or it can be from constantly having flaking, where they've done studies looking at how patients have problems in their relationships because they wake up in a pile of dead skin, and if they're sharing a bed with a partner, they're often embarrassed, and the partner is often annoyed by having so much skin in their bed as well. And that it can also affect patients' ability to work because they have frequent doctor's appointments, or some of their symptoms may be distracting them so much that they can't get their job done well. But probably more importantly is in the last decade, we really started to understand that psoriasis has a lot of other associated comorbidities. And part of this is related to the fact that psoriasis is a manifestation of skin inflammation, but patients tend to have overall inflammation in their body. And this can affect other organ systems. And we know that treating the skin lesions can decrease the overall inflammation in your body, and it may actually decrease some of the risk of other comorbidities. And probably the most well-known association of psoriasis with another organ system problem is psoriatic arthritis. And it is about a third of patients who have psoriasis will develop psoriatic arthritis. For some patients, you'll have psoriatic arthritis prior to the onset of your skin disease. For others, it may be simultaneously developing, and even for others, some people have psoriasis and develop psoriatic arthritis years down the line. But what we do know is that many people with psoriatic arthritis have a delayed diagnosis of up to 4 years following their original onset of their symptoms, and this persistent inflammation from the psoriatic arthritis can actually lead to joint damage. And what are some symptoms of psoriatic arthritis? We look for swelling and reduced range of motion in joints, swelling of the actual joints themselves and the associated tendons and ligaments. We look for nail changes because people who tend to have nail changes are more likely to have psoriatic arthritis. And then we ask about the areas that are affected. And a lot of times we'll see just one side of the body is affected, like just the knee or just these joints in the hands or the wrists. But you can see here that pretty much anywhere can be affected. And that the other thing we look for is what we call morning stiffness, where patients will wake up with very stiff joints that tends to get better after 20 to 30 minutes with movement, whereas osteoarthritis, for example, patients tend to wake up feeling okay and they develop more joint pains over the course of the day and with more movement. And the other things that we look for are other comorbidities that go with psoriasis and psoriatic arthritis. Some of these are eye problems, mood changes, swollen or bleeding gums, feeling fatigue, pain in the right upper abdomen that can be associated with liver disease. Some people have associated inflammatory bowel disease, such as Crohn's disease and ulcerative colitis. Patients with psoriasis also tend to be heavier and are more likely to have metabolic syndrome with high blood pressure, unhealthy cholesterol levels, heart disease, and diabetes. And then also psoriasis can rarely cause kidney disease. And then we also talked already about the painful stiff joints. This slide's actually from the American Academy of Dermatology Psoriasis Resource Center, so you can access it there. But what we also know is that there's good news that if you treat your psoriasis effectively or your psoriatic arthritis and follow a healthy lifestyle, you can definitely lower your risk of comorbidities and improve your quality of life. And one of the best ways to actually work on managing your comorbidities is with your primary care provider. So, the primary care provider is like your general practitioner or your medicine doctor or your family medicine doctor. They tend to have completed training in family medicine, pediatrics, or internal medicine, and they're really responsible for managing your overall health and facilitating any referrals to specialists and coordinating with your specialists so that there's still somebody managing all of your care centrally. So you'll see your primary care provider help you both with acute short-term and chronic long-term issues. They're the ones who'll be providing your regular checkups, and they're really the ones that should also be helping with your screening for comorbidities and making sure that you're getting all your preventative health care, such as your vaccinations. Um, and again, they're the ones who will also help refer you to specialists because some insurance companies will actually require that your primary care doctor refer you to the specialist before you're allowed to go there. So, how can you best manage your psoriatic disease as a patient? The main thing is first you need to make sure you get the correct diagnosis. And this can come either from your primary care provider or from your specialist. And then you need to make sure that you've decided on a treatment plan with your healthcare provider. And then after the treatment plan is decided, you need to make sure that you can actually get those treatments. And part of this, the barriers that patients experience with accessing treatments is not just getting the right treatment, but making sure that once the treatment is decided, the insurance company is willing to pay for it and that you can afford the copays that may be associated with some of your medications or therapies. And then also, just like we were talking about with the comorbidities, you really need to manage your overall health and not just your joints or your skin. So your PCP is essential in all of these steps, but a specialist may also be involved to best manage your psoriatic disease. And one thing I'll note too is that each PCP is very different in what types of psoriatic treatments they are comfortable with prescribing. And I actually did a research project last year that's ongoing looking at primary care providers and medicine doctors and their basic comfort and understanding of psoriasis. And what we found in our small sample size of about 20 primary care providers thus far is that most of them were able to actually diagnose psoriasis, but 75% of them felt that it was difficult to treat. Most primary care providers are very willing to prescribe topical steroids, but they're more hesitant to use the stronger topical steroids that we tend to use regularly to treat psoriasis. Um, and none of the people that we have originally spoke to prescribed phototherapy or biologic agents for psoriasis, and approximately 80% of them did not even know when they should prescribe these medications, and some also reported being worried about the side effects of the medications. So most primary care providers will refer patients to dermatology when they don't improve with their treatment plans, if they think they need a systemic medication or phototherapy, or when the patient has joint pain that's concerning for psoriatic arthritis and needs evaluation by rheumatology. And they also did a recent study that was published in one of our dermatology journals looking at the different amounts of training that primary care doctors received related to skin disease. And they found that only about 25% of internal medicine residents get any dermatology training, and 10% of those didn't even get any clinical experience. They just had a couple lectures. So it's not that primary care providers don't have any of the knowledge that they need. It's there's just so much for them to learn that you may really need a specialist to help you. So what specialists do we usually see involved in patients with psoriasis and psoriatic arthritis? The most common is a dermatologist to help treat the skin disease and a rheumatologist to help treat the psoriatic arthritis. And both psoriasis and psoriatic arthritis are really complex, lifelong conditions that require lifelong management plans as well. So, your dermatologist and your rheumatologist should work together with your primary care doctor to ensure that you are well managed, not just with your psoriatic disease, but also with your overall health. So, we really recommend that you see a specialist if you are in the moderate to severe psoriasis category, the 3 to 10% or above, or if you have psoriatic arthritis. Another time to see a specialist is even if you're not this severe, if you are trying a treatment for your primary care provider and it hasn't really helped over time, or if you're having flaring of your disease or worsening that you can't really figure out why things are going on. And one of the things that they know about specialists is that they receive a lot more training than general medicine doctors do in psoriasis and psoriatic arthritis. And because they're only managing one organ system at a time, they tend to stay more up to date on the latest developments and treatment. And for example, in my role, I do a lot of clinical trials. So many of the new medications that are coming out for psoriasis, I see before they're ever available to patients. And if you find a specialist that's involved in clinical trials, you may get access to some of these medications that are still experimental prior to the time that they're available to the general public, usually by about 3 to 5 years. So, the main things that we're trying to emphasize here is that we want patients to work with their primary care providers to make sure that their overall health is managed and that they're being screened for their comorbidities. So, at your PCP's office, we really recommend that you have your regular checkups, you get your blood tests, your vital signs, your physical exams, and your immunizations, and that you also talk to your primary care provider about making sure you're getting tested and screened for the various comorbidities that are associated with psoriasis. And these include metabolic syndrome, obesity, and type 2 diabetes. And I will mention that once you get to a certain age, most primary care providers will actually screen for these things routinely, regardless of if you have psoriasis or not. But it's always good to make sure that you alert your primary care provider to your psoriasis or your psoriatic arthritis and make sure you specifically address these comorbidities. And then again, for people who have psoriatic arthritis, we have them get screened for the signs and symptoms. We already discussed what they could be, but there is a way to better screen for them, and that is the Psoriasis Epidemiology Screening Tool, or PEST. And PEST is a validated tool for screening for psoriatic arthritis. And just so you know, a screening tool is basically one that we use to try to capture all patients who may be at risk for the disease, but it does not actually diagnose you with any sort of disease. So, for example, if you were to use this PEST tool and you answered yes to 3 of the questions, that would be a positive response. And it means that you should definitely be evaluated by someone for a healthcare provider for psoriatic arthritis, but it does not mean that you have the disease. And we recommend that people complete their PEST questionnaire annually. And if their primary care provider doesn't feel comfortable diagnosing psoriatic arthritis, that they refer you to a specialist with rheumatology. And this PEST screening tool can actually be found on the NPF website, and we'll have a link for that at the end of the presentation. And then just again, more tips that we've already kind of gone over, but if you want to maximize your time with your PCP, it always helps to be prepared. And this is the list of things that we would recommend you have on with you to talk to about your primary care provider: nutrition, exercise, getting regular checkups, screening for comorbidities. If you drink alcohol, this can actually be a trigger for inflammation and for psoriasis, and it can worsen many of the comorbidities associated with psoriasis as well as psoriasis itself. So if you need help limiting your alcohol intake, your primary care provider may be able to help you with this. And then if you feel like you're having any sort of depression or anxiety, the first place to go is to talk to your primary care provider and see if you need referral to a mental health expert. And we do have a brochure on the NPF website that explains how to work with your primary care provider, and I would really recommend reviewing this. And then if you have psoriasis and psoriatic arthritis and you don't have a specialist, you really need to learn to advocate for yourself. And we recommend trying to get a consultation at least once with a specialist, because they may be able to make recommendations to your primary care provider that they can carry out themselves once your diagnosis or your treatment regimen is established. And just make sure if you do see a specialist that they keep your primary care provider in the loop and ask them to either fax or send the notes from your visit to them for review. And the American Academy of Dermatology has actually been trying to really support the platform of teledermatology or telemedicine. So you may see in your doctor's office, especially if you're in a rural or an area where there's very few specialists, that they've been linking up primary care clinics with specialty clinics. And the AAD actually has something called Access Derm, where they've partnered with all local clinics, especially the ones that meet certain federal requirements, where they have AAD dermatologists, fellows, and residents volunteer to look at photos that are collected from participating clinics through this Access Derm platform. They're sent to us, reviewed, and then we provide our feedback back to the primary care provider or the clinic, and then they speak to you about the different treatment options and diagnoses. So if you want more information on this, you can look at the AAD's Access Derm platform. And then the NPF also, through their Patient Navigation Center, has partnered with a program called Dermatologist on Call, which does a similar service, but is usually associated with a fee. And then here's our resource slides, and that's the end of our presentation.
Great, thank you so much. So we are going to head on into our question and answer section. So if you do have questions, please submit those through the questions panel. We have been monitoring those, and we'll continue, and we'll get to as many as we can in the time allowed. All right, first question here. How many PCPs in America know what psoriasis, psoriatic arthritis is, and how to recognize, diagnose, and refer?
I think based on our research that we've done, most providers that are primary care doctors are very familiar with what psoriasis is, and they've been trained about it, and same with psoriatic arthritis, and they understand the steps to diagnosis. But the main problem they have is that they don't see it enough sometimes to diagnose the more complicated cases, and they also have more difficulty treating the complicated cases. So they're very good at treating mild disease, but anything that requires more intervention than that, I think they have a hard time kind of understanding what to do, but they know what it is.
Great, thank you. Next question here. If I don't have access to a dermatologist, but I have pustular psoriasis, what information would be best for me to communicate to my PCP to help me after a severe outbreak?
So pustular psoriasis is actually quite difficult to treat even for dermatologists. What we know, though, is that patients who have pustular psoriasis, even if they don't have a lot of body surface area involved, they're still considered to be moderate to severe, and they tend to be flaring quite quickly. So we usually recommend that they get therapies with something that acts very quickly systemically, such as like a cyclosporin or other kind of oral immunosuppressive entities, and then they usually transition then to another long-term systemic agent for management. But these are the types of cases that I would really recommend use the teledermatology platform to get access to a specialist if there's not a dermatologist locally that would be able to help treat the patient.
Great. Do you know of any research regarding removing tonsils to impact psoriasis, especially in kids?
Yeah, it was a couple years ago. It was either in the Journal of American Academy of Dermatology or JAMA Dermatology that they published a small case series on, it was probably between about 20 and 40 kids who had recurrent strep infections like strep throat and had psoriasis develop at the same time. That what they found is a good number of them, when they removed their tonsils, they actually didn't have any more psoriasis outbreaks after that, and they thought that the strep infection was really driving their disease. I think one of the limitations is in children, you never know because they're not followed long term if that trigger of the strep throat may have been something that affected them when they were younger, and as they get older, they may develop psoriasis again that is more sort of regular appearing in nature. But I would definitely look into that because there are a couple articles that have been published in the literature that you could probably find just looking up streptococcal infection in children with psoriasis.
Great, thank you. Next question here. Could you expand on the connection between psoriasis and other related conditions such as Crohn's?
I don't have the exact prevalence rates off the top of my head, but what they know is that patients with Crohn's disease or ulcerative colitis, which are both classified as inflammatory bowel disease, are more likely to have psoriasis, and the reverse is also true, that patients with psoriasis are more likely to have Crohn's disease and ulcerative colitis. Um, in hidradenitis suppurativa, for example, it's like 4 to 8 times more likely. I'm not sure if there's a similar study on psoriasis, but most patients that have Crohn's disease or ulcerative colitis require treatments with biologic agents like Remicade and Humira and Stelara. And all of those medications are actually also treatments for psoriasis as well. And so some patients that have overlap, their disease may improve, both diseases may improve with just one treatment option.
Great. I have one person asking to see the resource slide again, so I'm going to go back to that while we continue on with our questions. You can copy down that information. And let's see here. Next question is, what determines your primary care provider is not working with you? And can NPF help find a reputable primary care provider in my area?
I think that the first thing to take into account when you decide if your primary care provider is working with you or not is really make it clear to them what your priorities are as a patient, because some primary care providers, they'll focus on one medical issue that they think is more important in terms of your long-term health, but you may have another issue that you find to be more important for your current health. And I think just communicating that with them first is important so that you are on the same page. But I think after that, if you have an issue like psoriasis or psoriatic arthritis and you've been prescribed a treatment by your primary care provider and it hasn't helped, you usually need to give the treatment at least 3 months to work. So after that time frame, I would recommend that you ask for a referral to a specialist. I think in general, most primary care providers are kind of the same level of expertise in terms of treating psoriasis or psoriatic arthritis that is more moderate to severe. And rather than trying to change your primary care provider, it would probably be better to see if you can find somebody who's a specialist to help manage that disease in conjunction with your primary care provider. And they should communicate with them as well to ensure that any treatments that they do recommend to you don't interact with any other medications or any of your other health comorbidities.
Great, thank you. Next question. Can psoriatic arthritis lead to difficulty walking after intense activity?
So psoriatic arthritis can definitely lead to destructive joint pain over time if it's not treated, because essentially what happens is the inflammation from in your body as attacking your joints in psoriatic arthritis can destroy different parts of the joint and cause pain. And usually after you've done intense activity, you really stress those joints to the maximum. So that's why we recommend getting treatment, because over time, if it's not addressed, it can lead to permanent damage. I would say, though, that one of the distinctions I was making earlier was when people are diagnosing psoriatic arthritis versus osteoarthritis, they sort of look at the pattern of pain following activity. And for most patients with psoriatic arthritis, light activity tends to improve their joint pains, but for most patients with osteoarthritis, light or heavy activity tends to worsen those joint pains.
Great, thanks. Next question here. What is the reasoning behind doing a biopsy? I have one doc that wanted to do it and another one that didn't.
So like I said earlier, most doctors diagnose psoriasis based on the clinical appearance and what you told them about your history in terms of things that trigger it or your family history. But there are definitely other skin conditions that can look like psoriasis, and sometimes before starting a treatment, especially if they're going to use something other than topical steroids or other topical medications, some people will want to confirm the diagnosis with a biopsy. One of the problems, though, is that um, there's no 100% sure biopsy that you can say, I had this biopsy and this is 100% psoriasis. They may say, you have this biopsy and this is definitely psoriasis, but can't always be 100% sure. And the other thing I'll mention is there are some articles now talking about patients who are diagnosed clinically with psoriasis who ended up having another skin disease that when they treated them with the psoriasis therapy, they worsened because it was the wrong treatment. And it may be that one provider felt more confident in his clinical diagnosis and the other provider felt that a biopsy would help to confirm that diagnosis for them.
Great. Next question here. Are there specific lab tests that I should be requesting from my primary care provider?
So there's no specific lab tests that are related to the diagnosis of psoriasis or psoriatic arthritis that you would request from your primary care provider. There are a couple other arthritis diseases that they do have lab tests for, like rheumatoid arthritis, and your primary care provider may screen you for those to ensure that that's not the cause of your joint pain. But in general, just the basic screening labs, including like checking your liver, checking your kidney function, checking your blood count, checking your cholesterol level, and then also screening for diabetes are what we recommend for screening for the comorbidities.
Great, and we have time for one more question here. How safe are biologics?
I think this is the question that we get asked many times a day. So I will say that overall, we tend to consider biologics relatively safe. What we know is that all biologics work by suppressing part of your immune system, and because of that, that can have different effects on your overall function of your immune system and make you at greater risk for some infections. But we've had medications like Humira or adalimumab and Remicade and infliximab and Enbrel or etanercept that have been out for over a decade now, and they've been tolerated very well, including in pregnant patients over the last 10 years. There are some things that we know for sure that they are linked to, and those include the infection risk, but also patients who have neurologic diseases that are demyelinating, like multiple sclerosis. Those can be worsened by the biologic agents. And we also know that there's an increased risk of non-melanoma skin cancer, which is a squamous cell or basal cell skin cancers, which are the two skin cancers that don't tend to cause any problems in terms of long-term health or cause death in general. And so we do recommend that patients on the medications get screened. But some of the newer agents that are coming out are much more targeted for the psoriasis pathway. And we tend to think that they're a lower risk of infection because they're more targeted to just the inflammatory kind of signaling pathway that's related to psoriasis. But I think that before starting any biologic agent, you should really have a extensive discussion with your provider to talk about your overall health and your other medical issues to see if this is a good treatment option for you. And also, there's a lot of different online resources too that you can look at to kind of figure out what the risk would be, and you can talk to your provider about how likely those risks are to occur.
Great, thank you so much, and thank you again for sharing your insights with us. If you have any other questions, please contact our Patient Navigation Center by phone, email, live chat, or Skype. And once you leave today's webinar, you will receive a survey on the presentation, and we appreciate your feedback. If you can complete that, and thank you again to our sponsors, Celgene and Lilly. And finally, I just want to mention that a recording of tonight's webcast will be available shortly on our website. And you can access our complete webcast archive by visiting psoriasis.org/webcast. Thank you, everyone. Have a lovely rest of your day.